So thank you very much for joining for this talk. My name is Tom Carrell. I'm a vascular surgeon and one of the founders of Cydar, based here in Cambridge in the UK. These are my disclosures. So one of the big problems that we see and that we're trying to address is the problem that you have with disjointed planning, guidance and review in image-guided surgery in general and in endovascular surgery specifically. And the fact that that can lead to very different outcomes depending on where and who is treating you. It's perhaps not surprising if we look critically at how we do things today. When we come to plan, essentially what we're doing is taking a best guess of the technical outcome of the procedure. And we draw that up using some advanced visualization software, which is standalone. And we get a plan, or something we call a plan, which looks like a sketch and some measurements and some notes. And that's either drawn on a piece of paper or as a PDF. When we then come to operate, we have that piece of plan. We may bring it with us, we may tape it to the wall. But mentally what we're doing all the way through the course of procedure is remembering that plan and what we know about the preoperative CD, the kind of static imaging. And we're interpreting it in the light of the dynamic data that we're getting through the course of procedure. Of course, the X-ray fluoroscopy, any other information that we're getting from any other imaging modalities from IVUS or FORS or whatever. And also all the other bits of information coming in about hemodynamics, lots of other feedback, the tactile feedback that we're getting, the noises that we hear. And we're interpreting what we're seeing in the light of that original plan and really mentally adapting that plan for what we're seeing in the way of deformed anatomy and the rest. And the key thing here to think about is that the central processor of all of that information going on is a surgeon, a huge amount of information being processed at the same time. And we come sometime later in the comfort of a multidisciplinary meeting to sit down and we review what happened. We review the preoperative CD scan, maybe review the plan, the imaging from the course of the procedure, have a look at the post-operative CD scan, and we essentially qualitatively assess what the outcome looks like. We take any lessons from that, but really that learning experience is very much a local experience, shared amongst the team there in the room. So we have a vision for the way things could be different. We are a surgical augmented intelligence company, and so we're going to tell you a little bit about how that all comes together. So the central idea is something that we call intelligent maps, and this is a software system that connects the planning, the navigation, and the review for every case. Essentially, accompanies the patient throughout their journey. And it's giving the information all the way along so that each new case is informed by all previous similar cases, and each new case contributes to the planning and the outcomes of all future cases. Now, it can be a stretch to think about this in an abstract sense, but if you think about it, we are surrounded by very practical implementations of this every day. The satellite navigation systems that we use on our smartphones and our cars do exactly this. The way that it knows how long it's going to take you to get from A to B is because people have driven from A to B before it has that data. And yeah, it's using dynamic data as well in terms of the traffic and the rest to update what's going along to give you the best information as to which way to go on your journey. And the key bit in this is actually that what's going on there is fearsomely complicated. All the bits that are going on we could have previously got from an atlas and listening to the radio about traffic jams and all the rest of it. But essentially you've got a computer system in there, which is an AI, artificial intelligence, that has a model of the planned map, the planned procedure, and then it's updating that in real time for what's going on, and then it's integrating that and displaying it back with what we call context, which is defined as the right information, right time, right place. And that's the way we see this happening in surgery. I've used the smartphone Google Maps analogy, but it's everywhere we look in your cars that used to be massive dials, you now get alerts when particular systems fail. That's contextual alerts going on. If you look inside fighter aircraft is a good example. The aircraft themselves have got more complicated, but the user interface has got simpler and is prioritizing the right information, right time, right place to improve the situational awareness and the ability to be able to handle lots of information at the same time and extract the most meaning and insight from it. So how are we going about converting this kind of vision into a reality? Well, the first thing is there are 3 enabling technologies. The first and critical one is cloud. And that's actually the same for all the things you've seen before, smartphones and the aircraft as well. Because you have to have a way that you can connect the static data that you have, preoperative data in the case of surgery, to the real-time data as well. But you also need to be able to connect that to the pooled global data, which is what we call the pooled experience, so that what you're seeing and what you're interpreting there benefits from all of the experience of similar situations before. And then it has to be able to process that information, extract the meaning and the insights from it, and to display that to you with the correct context. And of course, the medical devices, this kind of capability is regulated as a medical device, even though it's software. You have to comply and be cleared with the various regulators, not just for safety and performance, but also for data protection and information security. Second enabling technology is data. None of this stuff works without large volumes of good data and the ability in the case of surgery here to be able to match up the 2D and the 3D data, so the stuff that is live, the stuff that is static. And then the third piece, which is really the bit that's really unlocked everything, is what's called AI, so artificial or augmented intelligence. And these are these simulated neural networks that learn in very much the same way that a child learns to recognize things, and have proved to be hugely powerful with all sorts of types of image challenges, but in this case particularly with, or notably with medical imaging. So the way we see that working in practice is something where you go to plan a case. The patient's anatomy is automatically analyzed for the geometry in terms of diameters, curvatures, the disease load in terms of thrombus and calcification. The pooled global data, that pooled experience, is searched, so you get reference to patients with similar anatomy. What were the technical outcomes on those patients? What were the statistics for endoleak, sealing zones, migrations? And then you, as the surgeon, you get to select the type of procedure you want. Remember, this is about augmenting, giving you the right decision, the right information for you to make the right decision. And then you interpret that and you make your judgment call as to how you're going to do things. And then having selected that, it generates a map and gives you the expected technical outcome, what that's going to look like, and the expected metrics in terms of what you can expect for the patient outcome. That same plan, this is crucial, then goes with you into the operating room, and it is there on the screen in the right place, all the way through the procedure, and it reacts to what's happening with the patient during the course of the procedure. So it's overlaid automatically on the screen in the right place. Just seeing where you are all the time makes surgery easier, faster, safer. And then it adjusts, because the anatomy changes, it changes too. The map changes as you introduce stiff wires, delivery systems, and the rest. And then you're saving the imaging all the way through. But then crucially, all the way through, also the machine learning, the AI is presenting the information that's relevant for the stage of the procedure that you're at or the events that are happening on screen. And then we come to review post-operatively, and you get all the metrics coming out. And this time, rather than a qualitative assessment, there's a quantitative assessment, so that you can see things about how closely does the final result match the preoperative plan, what are the metrics in terms of the sealing zones, the sac contraction, the endoleak, the patency, and the diameters. And then with all that information, again, linking it back to the global data, the pooled experience, what does that mean for that individual patient in terms of their risk stratification? What evidence-backed risk stratification that you can then use to inform that patient's individual follow-up plan. And then, of course, you can export it and you can link to registries and all the rest. So it sounds all great, fantastic, and there's a lot of hype out there actually around AI, but actually a lot of this is reality already, and we've made huge progress towards the vision. I want to show you what it is today and what you can get your hands on and use today. We call it intelligent maps. So first thing, the cloud system exists. It is in routine, regulatory cleared use in 6 countries across EU, UK and US. Real time, real supercomputing power being, that attention being paid to each individual case that you operate on. Really frequent updates. One of the nice things about the cloud is we can be constantly improving, bringing in new capabilities. We're on version 92 at the moment and over 2,000 cases done to date. Regulatory cleared, CE marking, FDA, and compliant in all those geographies for the data protection, GDPR, and information security and HIPAA. Using it consists of, well, the clinical workflow consists of 2 key steps, which are creating a map and then the intraoperative use, which is the computer vision that we call image tracking. To create a map, you log into your account through a desktop or a laptop, and you can search your hospital packs, retrieve a CT scan. The AI then automatically segments out the blood vessels that are relevant to the procedure or that it thinks will be relevant. You get a chance to edit them. And because that's using the deep learning, it doesn't work like conventional algorithms. It's really robust and relatively insensitive to high or low contrast CT scans, which can trip up the conventional algorithms. It puts something that we call virtual wires inside the blood vessels. Now, these are guide wires inside the segmented blood vessels that you can use for 2 things. You can use them for measurements like a standard center line in an advanced visualization planning tool. But you also use those intraoperatively to deform the anatomy, to update it, to match it for the real-time anatomy during the course of the procedure. You might have seen a little video there playing. There's also some AI in terms of putting target rings on the branch vessels that you have as well. And you preview the map that you're going to have with you during the course of a procedure. Then when you come to operate, it kind of couldn't be simpler. In the operating room, there's just a PC. As I said, there's no real hardware involved. Presents a list of the patients who have maps. You pick the patient you're operating on, you confirm their identity. You then don't actually need to do anything. The image tracking computer vision just watches the fluoroscopy. When an image appears, it gets to work and overlays a map. And that map there, we've so far overlaid about 250,000 unique solutions in real clinical use, and there hasn't been a detectable error in a single one yet to date. So to be clear, that green map is the preoperative map being overlaid. And so you will see discrepancies, as you can see there on the right at the moment, between where the map is and where the real-time anatomy is. Now, crucially, that's telling you the anatomy has changed. Okay, it's not that the overlay is in the wrong place. The anatomy has changed because of the stiff wires and the stents in there. Now, the way that the anatomy changes is complex. It's not a case, you just can't fix it by panning it around or zooming in and out the rest. It's because the blood vessels, when you put in stiff wires, they straighten, they shorten, they displace. It's a really, really complex transformation, non-rigid transformation that's going on. And there's also other stuff going on, like the patient's lying on the operating table in a different posture than when they had the CT scan. So the way the image tracking system is, the AI is accounting for that. First of all, whenever the scene changes, it just recognizes that the scene has changed and just updates the map. So here we go, here's a video. It's overlaying the preoperative map, you can tell by the green color. Scene changed there. I think the C-arm moved and the field of view changed as well. Just removed the old map. There was a burst of supercomputing power. It's worked out now the perspective that the X-ray set's looking at the patient from, and produced a new map and overlaid that on the screen. And there we go again, same thing. Oh, they continue moving it. In the background, I was alluding to the posture change. It's recognizing how the relative positions of the vertebrae have moved compared to the preoperative CT scan, and it's constantly adjusting and updating the map to take account for the patient's posture on the operating table. That's all invisible, happens behind the scenes. And then the big one, which is the deformation, which is when you've put in the stiff wires, as we saw earlier on, and the anatomy has changed. And so with this, you can either see it from the position of wires or you can see it on a DSA. So DSA comes in, and then when you have a look at the map, it doesn't match up. We're kind of expecting that because there's a delivery system in there, but you can now just adjust that 3D map. You do use a remote control, it's a few clicks. Non-rigid, remember it's like bending a plasticine model. So you probably adjust here on the renals. The renals always seem to move upwards with infrarenal stiff wires. But you can now move the suprarenal aorta in one direction, and you can move the infrarenal aorta in another direction. And you can just make it update. Now, it doesn't matter now what perspective you're looking at from. You can come to a different field of view, different angle, but it's remembered that updated anatomy. And so you now got that essentially as your reference for what the real-time anatomy is. So that's all available today, very, very pleased with the impact it's having already. But there's more coming. And what's coming down the pipeline is contextual displays for the right information at the right time. So first thing is understanding the events. This is a glimpse as to what it's able to do at the moment in terms of recognizing when delivery systems appear, which is green. That's actually even specific. It tells you which manufacturer it is. Or it's specific to each manufacturer. It doesn't actually tell you. And also recognizes when the stent is deployed. So with those two bits of information, you can detect the event effectively that this is a stent graft of such a manufacturer being deployed. And then the next bit for context is right time and right place. So what you're seeing in the video there is, again, it's live in the product at the moment behind the scenes, just recognizing what is going on with the imaging, the type of imaging there. But we can stitch things together or over the course of a procedure and work out, as being shown on the image on the top right, but essentially that there's a stent being deployed separately, one time in the right common iliac artery and then in the infrarenal aorta subsequently. And you begin to put all of these things together and work out what step of the procedure, what stage of the procedure you're at. So I'll finish there. It's a hugely, hugely exciting space. I think really the big thing in this next kind of generation in endovascular surgery are going to be the insights that we get from the imaging and joining up all of these incredible new capabilities with things. And the great thing about cloud is that you literally, each time you switch it on, you get the latest version of it and the latest capabilities. And certainly at the moment, those capabilities seem almost limitless in what they can do in terms of improving our understanding of what's going on during the course of procedure and improving the predictability and the consistency of outcomes in image-guided surgery and in endovascular surgery in particular. Do get in touch if you want to hear more about it. Thank you very much.